estimate that average woman, really no family history, no risk factors, has about a 1 in 8 chance for breast cancer, which translates into a 12% chance. So, in other words, if we had a room of 8 women, just selected at random, roughly one of those women in that room in her lifetime would have a breast cancer diagnosis. But if someone has a grandmother who had breast cancer, the risk is about 1.2 times higher than the average person. So, what does that mean in terms of actual numbers? Well, remember the average woman has about a 12% risk for breast cancer. Having a grandmother increases that risk up to about a 15% chance in a lifetime. So, a couple percent higher than the average person would have. So, we roughly go from 1 in 8 to a 1 in 7 chance of breast cancer. If someone has a closer relative with breast cancer, say for example a mother or even a father, because men of course can have breast cancer, or a sister, the risk is even a higher risk than a grandmother. It's about 1 and 3/4 times, or 1.7 times the average risk, and that translates into just over a 20% chance in a lifetime, or about a 1 in 5 risk for breast cancer with a close relative, compared to the 1 in 8 chance most women would have. Now, if we go down to the bottom point on this slide and we say, well, what if someone has two first-degree relatives? In other words, two close relatives like two sisters or a mother and a sister with breast cancer. The risk is pretty close to 3 times what the average person's risk would be. So now we're up to a little bit over 30%, or about a 1 in 3 risk for breast cancer. So this slide just illustrates what we were talking about before, which is the more relatives, the closer they're related, the higher the risk would be. Now I'd like to switch gears and bring you all a little bit into my world in terms of genetics and how that pertains to risks for health problems. And so I'll take you all back to your biology class days here for a couple minutes. First of all, what is DNA? We've heard about DNA. It's been talked about a lot in the media, on TV, and in print. And DNA is, chemically speaking, something that's called deoxyribonucleic acid. And it is actually the genetic molecule or the genetic material in humans and almost all other organisms. DNA really is like a blueprint. It contains information that determines how we look, how our bodies develop, how our bodies work. So basically everything about how we look and how our bodies work, every trait that we have. So DNA is literally like a blueprint. On this slide, I have information that goes over how we can get from a cell down to the level of a gene and a protein. The human body is made up of billions and billions of cells. Inside each cell, we have a control center, or almost like a brain in the cell, that's called the nucleus. And inside the nucleus is where we have our DNA, or our genetic information. The DNA is packaged into pieces that are called chromosomes. And all along the length of each chromosome, we have literally hundreds to thousands of genes. It's really an amazing setup that we have in terms of our genetic information. The latest estimate is that people are thought to have something like 20,000 different genes that make up their genetic code. So it's really a lot of information. And a gene is like a recipe. It's a recipe for the body to make protein. So this is just a broad overview of genetics. Now we have to talk about mutations. Mutations are changes or alterations that can happen in genes. Mutations in certain genes can be associated with risks for cancer. So we have certain genes that have that link with cancer when they're not working the way that they should. Mutations, or these differences or alterations in genes, can be either inherited from a parent or passed down from one generation to the next. And in a scientific way, these are called germline mutations because they're in the reproductive or the germ cells. Or mutations can be acquired or picked up sometime during a lifetime after conception. These are called somatic. So an example of a situation where someone might acquire a mutation, say that someone is maybe swimming in a lake and they have an exposure to a chemical that's in the water, and maybe that exposure, that chemical causes DNA damage or mutations to take place. This would be an example of a mutation that was acquired, not one that was inherited. So mutations can be passed down from a parent or inherited, or they can be acquired after someone is conceived or born. Cancer does arise from gene mutations. Again, some people can inherit, on the left of the slide is that circumstance, inherit a germline mutation from a parent. This is passed down through the egg or the sperm when the child is conceived. These are the type of mutations that I test people for and genetic counselors look for when we're thinking about a possible inherited risk for cancer. However, mutations, like I mentioned, can also be acquired. These are not inherited. They do not occur in tissues that are passed down from parent to child. And these sorts of acquired mutations are common and happen for all types of cancers. Most people that have a cancer diagnosis do not have an inherited mutation that put them at risk for it. Most people had mutations that occurred probably because of things they were exposed to in the environment over time or happened for other chances or reasons we don't understand. But we can definitely say that gene mutations and genetic damage is a common thread and a necessary piece for all cancers to occur. So on this slide, that says basically in a neater way what I just said, all cancer is genetic, but most cancer is not inherited. So we have these mutations or these genetic differences that happen in our cells that can set the stage for a cancer. Most of these are acquired during our lifetime, but are not inherited or passed down through the generations. I'd like to focus now on hereditary breast cancer. We've really come a long way with our understanding of the genetics and the inheritance of breast cancer since the two primary genes were discovered in the mid-90s. These are called BRCA1 and BRCA2. That stands for breast cancer 1 and breast cancer 2. Sometimes they're called the BRCA genes. So hereditary breast cancer is definitely a focus and one that we always think about when there's multiple cases of breast cancer in a family or people that are potentially younger than average when they're diagnosed. But on this slide, we're looking at how much of breast cancer and ovarian cancer is hereditary. If you take everybody that has a breast cancer diagnosis, all women, those that are in their 20s, those that are in their 90s, and every point in between, all women that have a breast cancer, it's roughly 5 to 10% have truly an inherited reason for why it's happened. So roughly 1 in 20 to 1 in 10 women with breast cancer have a gene that was inherited that put them at risk for that cancer or a mutation that was passed from parent to child. So it really is not most people, it's really the minority of people with breast cancer have an identifiable inherited risk factor for it. A lot of breast cancers are sporadic, meaning that they're occurring in families as single cases in a family, just one person. Sometimes we can see a cluster of breast cancer, and that just means 2 or more people in the same family who've had breast cancer. But then again, sometimes it's hereditary where there's an actual gene that's involved. Ovarian cancer, it's a little bit higher number of women have a hereditary risk with an ovarian cancer diagnosis, but for the purposes of our conversation today, about 1 in 20 women with breast cancer have an inherited risk. This is a very important slide, maybe one of the most important ones that I'm going to put up here today, because these are the clues that we look for that tell us who is more or less likely to have an inherited risk for cancer. Now, I really can't comment about people's individual family histories in a format like this, so I would encourage anyone that has a family history that they're concerned about to share that information with their doctors. I really need to see the full family tree before I can delve into it and give any feedback. But for the sake of today's presentation, these are the things to be thinking about in reference to your own families. If any of these criteria are met or true, then you should consider talking with your doctors about meeting with a genetic counselor, or considering genetic testing. So the first one is, do we have people in the family who are younger than average when they had their diagnosis? And by that, we typically mean under age 50. Are there multiple relatives in the family that had an early onset breast cancer? So take, for example, a family where we have two sisters with breast cancer in their 40s. That would definitely qualify. Ovarian cancer in a family, especially if there's a history of breast cancer in the family, gets our attention because these two cancers, breast and ovarian, can be linked together in the same family because of the same inherited risk factor, especially with the BRCA1 and 2 genes. Also, if we see the same woman who's had both breast and ovarian cancer, not cancer that spread from point A to point B, but two separate cancers that happened independently of each other. They could be at different times or they could be at the same time. Women that have had bilateral breast cancer, and that would be cancer in both breasts, so both sides where there might be a breast cancer, is definitely more suggestive of an inherited risk than just one breast cancer in the same person. And this is not cancer that spread from one breast to the other, but actually two separate breast cancers. Any men with breast cancer are definitely some history we should take note of because men are very rarely diagnosed with breast cancer. About 1 in every 1,000 men in their lifetime will have a breast cancer diagnosis. But if a man has breast cancer, that should be an automatic question. Could there be a hereditary reason for the diagnosis, no matter what age he was diagnosed? And finally, if people have Jewish heritage or Jewish ancestry, especially what's called Ashkenazi Jewish ancestry, which are people that originally or their ancestors came from Eastern Europe, in the Ashkenazi Jewish population of all groups of people, we see the highest rate of hereditary risks for breast cancer. In other ethnicities such as African American, Caucasian, Asian, Native American, we have roughly the same incidence of these hereditary factors, but in people that are of Eastern European Jewish ancestry, they have the highest risk for a hereditary possibility than any other ethnicity or group of people. That probably relates back to the fact that people of this background have been isolated for religious reasons from the rest of the population, and sometimes because of geography or location. So the frequency or the number of people that have a hereditary risk have increased. There is a condition that's called hereditary breast and ovarian syndrome, sometimes abbreviated as HBOC. And this particular condition happens when a person has inherited a mutation in either the BRCA1 or BRCA2 genes. These are DNA repair genes. We want them to be doing their job at all times. They're good genes when they're working. These two genes account for about half of all the hereditary breast cancer families that we can identify, and even a higher number, about 90% of those families that have an inherited risk for both breast and ovarian cancer. About 1 in every 500 people that are of European, African, or Asian descent have an inherited mutation in one of these two genes, in BRCA1 or 2. But about 1 in 40 people that are of Ashkenazi Jewish background or of Eastern European Jewish descent have this hereditary risk. So that's like what I was talking about on the last slide. But in general, most people in the United States that are not of a Jewish background have about a 1 in 500 risk to have one of these inherited risk factors. On the next two slides, I'm going to show how different the risk for cancer actually is for people that have inherited a mutation in BRCA1 or BRCA2 genes. First, let's look at breast cancer in women. Remember, the average woman has about a 1 in 8 chance of breast cancer in a lifetime. A woman that has inherited a BRCA1 mutation has from the mid-50s up to almost a 90% risk for breast cancer in a lifetime. This is a huge increase over what the average person's risk would be. So to think about this another way, if we had a room of 10 women all having a mutation in this gene, at least half of those women, 5 up to maybe 8 to 9, would have a breast cancer diagnosis in a lifetime on average. So that's a major difference in the risk. And if someone has had a breast cancer and they treated that breast cancer with the least amount of surgery possible, that's a lumpectomy. If they have a mutation in this gene, they have up to a 40 to 65% chance, or about a 50-50 chance, of potentially having a second brand new breast cancer happen that is completely independent of the first one that took place. So when we know the risk is higher, we definitely do things differently for people than we might not do otherwise, and I'll go over that on one of the upcoming slides. We also have a separate risk for women to develop cancer of the ovary, and it's about a 30 to 45% chance of ovarian cancer. Men with BRCA1 mutations do have increased risks for breast and prostate cancer, and there is some evidence to show that there's also an increased risk for pancreatic cancer. So it's more than just breast, it's other places in the body as well. With BRCA2, the other gene, we have similar risks for cancer. The breast cancer risk for women is basically, as far as we can tell, the same as the other gene. The risk for ovarian cancer is a little bit lower, a 10 to 30% chance in a lifetime. And the risk for men to have breast cancer is better understood. It's about a 6 to 8% chance, which is very similar to what a woman without a mutation would have in terms of cancer risk, and increased risk of prostate, pancreatic, and possibly other cancers as well. What can we do? How can we help people that have this hereditary risk because of these genes? Well, there are many, many options we have, and the same options are not necessarily right for everybody. But if we find out someone has a mutation, what's called a positive test result, we hope we can identify other relatives in the family that may have the risk. With these genes, we don't have evidence that inheriting a single mutation increases the risk for children to have cancer. So we typically start to think about genetic testing at age 18 and up. What do we have to offer? Well, we have increased screening and surveillance. We wouldn't want to wait until 40 to do a mammogram. We would actually want to start with breast imaging studies, including possibly breast MRI in addition to mammogram, by the mid-20s. So we would start much younger than we typically would for the average person. We would also want to screen people by doing breast exams at the doctor's office, and for women to be very vigilant and careful about their own breast self-exams. So we increase surveillance. We start younger, we do more to watch for breast cancer in hopes that if it does happen, it would be found early when it's curable. We also think about what can we do to prevent cancer from taking place. Chemoprevention should not be confused with chemotherapy. Chemoprevention is not chemotherapy. Chemoprevention is taking certain medications orally or by mouth that can hopefully reduce the risk of breast cancer. One such example that's been studied in the hereditary setting is tamoxifen. And tamoxifen is a medication, like all medications, that has risks and benefits, and everybody has to review those with their physicians if they're offered or considering taking a medication. We then have prophylactic surgery. Prophylactic means preventative. So some women decide that they want to take steps to prevent a breast cancer or an ovarian cancer by doing a surgery to accomplish that prevention. So most people heard last year that Angelina Jolie made an announcement, and that was that she had her breast removed surgically because she had an inherited risk for cancer. The gene that she has a mutation in is one that we're talking about now. It's the BRCA1 gene. So she made that decision, and it is an option for people, but not a must, not the right decision for everybody, but it is an option and does significantly reduce the odds of breast cancer. So we have these different options for people, and there are some things we have for men as well, starting prostate cancer screening at younger ages, also potentially doing some breast cancer screening by doing breast exams and even mammograms for men if they have enough breast tissue. I'd like to switch gears for the next two slides just to bring to your attention that there are other hereditary conditions that can increase the risk for breast cancer. So that's why it's important to have a trained genetics professional or someone that's very familiar in looking at family histories to evaluate which genes to consider. So there is a condition named after the first two doctors that described it in the late 1960s called Lee-Fraumeni syndrome. This particular condition is caused by mutations in a different gene called P53. People that have mutations in this gene have roughly a 50% risk for breast cancer by the time they get to be 60. So it's a significant increase in risk. And we can also see risks for other cancers, some occurring in childhood, including cancers of the brain and blood. Those can occur in childhood, or leukemias. We also see risks for connective tissue cancers that are called sarcomas, which come from places like bone, muscle, and cartilage. And what's been found is that about 5% of women with breast cancer who are 35 or younger when they're diagnosed and don't have a BRCA1 or 2 mutation will have a mutation in the P53 gene. So that's why if people have had genetic testing, especially if they were 35 or under, and they didn't have a hereditary risk identified, it might be worthwhile to follow up with a doctor or a genetic counselor again to revisit this topic. And the next condition I'll review just briefly is called Cowden Syndrome. And this is named after the first family that was found to have this. And it's caused by mutations in a completely different gene called PTEN. Lifetime risk for breast cancer with this condition is significant at up to an 85% risk in a lifetime. There are also risks for other cancers, including thyroid, uterus, kidney, and others. And we look for other things in family histories that aren't cancer or aren't malignant. We sometimes measure people's head circumference because people that have this tend to have a little bit bigger than average head size. And there are also benign growths that can take place other places in the body. So this just goes to show a little bit of the complexities and the facets of looking at a family history and trying to assess what are the chances of a hereditary risk and what genes to consider. Now I'd like to switch gears and go over some information about genetic testing. This is how we actually can prove or identify that there might be a risk for cancer in a family. First of all, we usually do testing on some sort of a sample from the body. Blood or saliva or mouthwash are the typical samples that we use. We just need some source to be able to get DNA or genetic information from a person. Most insurance companies do cover the cost of genetic testing if criteria are met, and there are published criteria that most insurance companies go by, and a lot of them are based on the ages that people are diagnosed in a family and how many people in a family have had cancer. Test results don't come back overnight. They can take several weeks up to several months to be reported out. So this is also a consideration. Results are sometimes not clear. We can get results back that are inconclusive, which leaves us wondering what exactly did we find? Sometimes we can find genetic differences or changes of unknown significance. We don't know if what we found is truly a mutation that increases the risk for cancer in a family, or if it's just a benign change in the gene that does nothing at all. So these are some important things to talk about before a test is even performed. Benefits of genetic testing include the possibility of a better understanding of what level of cancer risk is present. How high is the risk? People can then take that information if they have a hereditary risk found and make decisions about lifestyle. Maybe it would reinforce eating better or stopping smoking or other things that we know we should do and sometimes are hard decisions to make. Also, it can help people to decide if they should take any medications, chemoprevention, that can reduce the risk of a cancer. Cancer screening and cancer surgery are also key parts to knowing your risk and then being able to act upon it. And finally, the ability of genetic test results to potentially help other family members. Take, for example, a person that has a hereditary risk identified, and then that knowledge could help her children or her siblings, because when a parent has a risk like this, there is a 50% chance they'll pass that cancer gene or that risk for cancer to a child. So it definitely has implications for other people in the family. Some considerations about genetic testing. Genetic testing is certainly not for everybody. And when a genetic counselor meets with someone, we view it as an opportunity to provide information, but never an opportunity to persuade people or convince them to do a test. Sometimes people can have emotional reactions, very understandable. If someone learns they have an inherited risk for cancer and they may have passed that risk to a child, that can be a very hard emotional burden to carry. Not everybody wants that information or is prepared to learn it or deal with it. And also the concern about future cancers for an individual who's already had a cancer. It can be very, very difficult for someone to learn that they may be at risk for new cancers to take place after already being a survivor from a previous cancer. We do consider testing minors or children if there is a risk for cancer in childhood. And some of the genes I've reviewed have a risk like that, and some don't. Results can be non-informative, meaning if we do a genetic test and we don't find something, it doesn't necessarily prove that there's not a risk for cancer in that family. Our technology with genetic testing is improving rapidly, and there are many genes that are being discovered every probably month to year that are new genes that we haven't known about before. So non-informative results are we didn't find a hereditary risk, but we can't guarantee maybe there isn't something there that we wouldn't find a few years from now. The genetic testing information is confidential, as confidential as anything else in the medical record, but people sometimes do have concerns about where the information will go. But it is protected under the HIPAA law or the privacy law with health information. Sometimes people have fears about genetic discrimination. Could there be some negative repercussions if this was known for a person or their family that they had a risk for cancer? We do have two laws in place, HIPAA and GINA, that say that it would be illegal for a health insurance company or an employer to use genetic information to discriminate against a person. So someone might say, well, I'm worried if I have a risk for cancer or a mutation in one of these genes, could my insurance company charge me more for my health insurance? Could they drop me altogether if it was known by them that I had this risk? And according to federal law, health insurance and employment cannot be impacted. Well, we do know, though, that we have very few things in life that we can guarantee are impossible. So I never tell people that this is an impossibility with genetic discrimination, just that it's a very low chance of happening based on the laws we have passed. And another consideration is that genetic testing or finding out that there is not a hereditary risk for someone does not eliminate other causes of cancer. So, say we have a woman whose mother had a mutation or a hereditary risk, and this woman did not inherit it. Well, she still could have a cancer for another reason. About 1 in 8 women have breast cancer. So, even if someone does not inherit a risk that's in their family, it doesn't say they have a zero risk for cancer. I'd like to hopefully draw all these different points and topics together by going over a case example. Some of the details here have been changed to protect the anonymity of this person, but this is based on a real person that I met with. So we have a 46-year-old woman who is diagnosed with a particular type of breast cancer called a triple negative breast cancer in her left breast. She had a grandmother on her father's side of the family that had breast cancer at a young age, who was 45, her grandmother on that side of the family. So automatically, I hope you can see that there are some things about this family that make it concerning. We have two women who are under 50 when they were diagnosed with breast cancer, and two relatively close relatives. We have a granddaughter and her grandmother. And also notice that I have a history here of the grandmother being on the father's side of the family. The paternal family history, the father's side, is just as important as the mother's side because cancer risks can be passed down through both sides of the family. This particular person was an only child, as was her father. So it's not like we have a big family here with lots of women to see what would have happened. It's a small family. She stated that she would change her surgical decision making if she had a mutation in one of these genes. In other words, she was planning on having a lumpectomy, but if she knew she had this hereditary risk for cancer, and up to a 65% risk for a new cancer if she did just a lumpectomy. She might decide to do surgery on both sides. And this person's ovaries are present, intact. She's never had them removed. And remember that BRCA1 and 2 mutations also increase the risk for ovarian cancer. This particular individual postponed her surgery until after her results were available, and in fact, she did test positive for a mutation in BRCA1. She has since had bilateral mastectomies and has a plan to do some additional surgery involving her ovaries in the future. Her 22-year-old daughter had genetic testing, but her results are not yet available. So here we have a family, young ages of diagnosis, multiple people. The individual did have a hereditary risk identified, which has implications not only for her, but also for her daughter. So in summary, genetic counselors help patients understand and adapt to the implications of genetic diseases and hopefully to make some decisions about genetic testing that are informed and definitely within their own control. There are multiple risk factors for breast cancer above and beyond just family history and genetics. It's all part of the big picture. All cancer is genetic, but most cancers do not happen because of inherited reasons. And the chances of having an inherited risk for breast cancer is determined by someone's personal and family histories. Finally, genetic test results can impact medical management. What I have listed here at the bottom of the slide is the website for my professional society. It's the National Society of Genetic Counselors. On this website, there is a directory which you can put your zip code into and find genetic counselors that live and work in your areas. And again, I really am kind of limited about what I can address in terms of people's individual family histories, but I would welcome any general questions that you would have, and I thank you for the opportunity to present to you today.
Thank you, Eric. This is Kate with Cancer Treatment Centers of America. We'd like to now open the floor for questions. So we'd like you to actually use the chat box to type in your questions, and then we'll have Eric answer them. So feel free to start typing if you have any. While we're waiting for the first question, I'd like to remind everyone to please like Sisters Network on Facebook and follow them on Twitter and Instagram. And some questions. Okay, not a question, but Marilyn said, thank you. You did a great job explaining the information. Thanks, Eric.
My pleasure.
We have a couple more questions coming in. Okay, so a question from Mona is it too late to have genetic testing after having surgery?
It is absolutely not too late to have genetic testing after having surgery. The genetics is not changed at all after a surgery. If there was a hereditary risk present, it was there from conception, and it will always be present in the body. And even though a person might not be interested in changing their surgical decision, it could still help for them to know what other cancers they might be at risk for, and also to help family members. So it's really never too late to have genetic testing after surgery or not. Very good question.
Wonderful, thank you, Eric. So Betty said, quite informative, many thanks. It looks like we have a couple more coming in. Okay. Okay, so Marilyn said, I missed the last point you had on your slide about Cowden syndrome. What was it?
I think I'll probably just go back up to that slide so we can take a look at it together. Sorry that I'm going to be toggling through here, but sorry, we're just working out a little. Here we
Okay.
go. So the last point on of the slide for Lee from Anysom, thank you for asking that. So if a woman is 35 years old or younger when she's had breast cancer, and if she's already had the genetic testing for the BRCA1 and 2 genes and nothing was found, it's reasonable to potentially think about having this genetic test for the P53 gene because about 5 to 7% of women who previously tested negative had no hereditary risk with BRCA1 or 2 that are 35 or under when they were diagnosed will in fact have a P53 mutation. So this is where genetic testing is changing very, very quickly. We're kind of coming across new ways to consider testing people and new genes to consider in certain circumstances. And also, while I'm thinking of it, I would say genetic testing for BRCA1 and 2 has changed rapidly over the years, and our ability to find mutations now is much better than it was even as recently as 5 to 7 years ago. So, if people had genetic testing in the past, it might be worth revisiting with the doctor. Was it the complete test? Is it the test we have available today? So genetic testing changes quickly over time. Now I'm seeing some more questions come up. Hopefully we have a
Okay.
question about how long this webinar will be on the net, and I'll give this back to
Oh,
Kate.
thank you. So I'm gonna go down. That's actually a question for Kelly with the Sisters Network, who's unfortunately having some technical difficulties. So Betty, if you want to jot down my email, it's up there. It's katepeterson@ctc-hope.com. And send me that email. I'll get it to Kelly to find out the answer to that question for you. Katie also asked, what age would you recommend testing for a person with a family history of BRCA1?
So I'm assuming that you're talking about the genetic test, and typically we start offering testing for people at age 18. The reason for that is there's not any evidence of risks for cancer in childhood for people that have a BRCA1 mutation. And not everybody at 18 is ready to do the test or even wants to know at all. Medical management changes pretty dramatically for people with BRCA mutations by the time they're in their mid 20s. So if someone were not ready to be tested, maybe they were starting a career or going to school, maybe they would sometimes think about postponing until their mid 20s. But it's a very individual decision, but probably not before age 18 would we consider doing the genetic testing for BRCA1. And I see another question from Marilyn about Cowden syndrome, and I'm going to try and go back up to that slide and look at the last point there. So Cowden syndrome, the last point was there are non-cancerous features that go along with this condition. So you have to, when you're considering this as a possibility for someone, you want to go to someone that's trained to look for these things, which I always carry a tape measure in my pocket because I'll get it out in a moment's notice to measure people's head circumference. Not something people expect when they're meeting with a genetic counselor. But there are also benign growths that are not cancerous that can happen in certain places in the body, like the breast, the uterus, the thyroid, the mouth, and the skin. So when a genetic counselor or another trained professional is looking at a family history or talking to an individual, we will, if we're considering this condition, sometimes delve a little bit deeper and ask questions that have nothing to do with cancer, but have to do with some of these benign findings. I am seeing some questions from someone that's talking about having a lumpectomy and that tested positive for a mutation in BRCA2. I don't want to be in a position here to give medical advice, but I think that any woman that's tested positive has to weigh in her own mind what her tolerance is for living with risk for the future. There are some studies that have come out that show that potentially mastectomies in certain circumstances, when a person has a mutation, may not change survival rates, but it's a really individual decision as to decide what is the right step for, for a person. Certainly, it is fair to say that bilateral mastectomies, when a person has a mutation, do reduce the risk more than anything else would. And if that tissue is gone, then we reduce the risk for a new cancer by at least 90%. But each person has to talk about that with their own doctors. And I do recognize that it's a very difficult decision to make because of the changes to the body and how body image may be affected. And it's a surgery. So, again, to think about this from a medical standpoint, I encourage people to talk to their doctors and get their opinions if they test positive. But ultimately, it comes down to the fact that this is your body and it's your right to make those decisions.
So the last comment is from Betty. It says, Sisters Networks, congrats. This is a great way to celebrate your 20th anniversary. And I agree. So with that being said, I want to respect everyone's time. Thank you so much for joining us. I hope that as you're signing off, you have more knowledge than you signed on with. Also, I just wanted to share with everyone that Webinar Wednesday is continuing. On Wednesday, June 18th, from 12 to 1 Central, Dr. Jag from our sister hospital, Cancer Treatment Centers of America in Tulsa, will be presenting on metastatic breast cancer. So you'll receive an invitation for that, and I recommend everyone join that as well. And then I just want to thank everyone again for joining. Thank you, Eric, so much for presenting, and I hope that you enjoy the balance of your day. Thanks, everyone. Bye.